Today, what I'm going to turn to is the second part of the economic applications, focusing on health insurance. So there's an even bigger literature focused on health insurance and health care and how that affects outcomes and costs and so forth. So that's going to be the first thing we talk about. And then towards the end of today's lecture, I'm going to give you a flavor of a very different field, a different approach to thinking about improving population health, which is from epidemiology rather than economics. Talking specifically about using big data to forecast the spread of diseases, to forecast pandemics. Okay, so we'll start by talking about the economics of health insurance and health care. And here, it's a big field. What I'm going to cover in the next half hour is just a tiny snapshot of what people are doing in this area. But broadly, health economists focus on studying markets for health care. So what are the types of questions people are interested in answering? Will expanding health insurance coverage improve health outcomes and reduce health inequality? So obviously a central question in the context of the debate about Obamacare, Medicare, and so forth. And if we think health insurance coverage is really valuable, how can we provide health insurance to more Americans? Should we do it through a mandate, as was done in the context of Obamacare, where there are these health insurance exchanges, and if you don't buy health insurance, there's a penalty? Or should we have just universal health care provision, as in Scandinavian countries or in Canada? There are many different approaches you might take. Okay, so I'm going to first start with the first question, insurance and the demand for health care. So the basic question we're asking here is, what is the causal effect of insurance on demand for health care and on ultimate downstream health outcomes? So in particular, the debate in this area, you might think it's kind of obvious, of course, giving people more health insurance and healthcare has got to be good for you. But the debate is whether providing individuals insurance actually encourages wasteful spending, so people just get more tests and get more kind of unnecessary care, or does it actually improve health outcomes in a way that's cost effective? So how would you answer this question? As we've now seen many times in this class, it's always useful when you're trying to ask a question about causality to step back and ask, what is the ideal experiment that you would run in order to answer this question? And so what is the ideal experiment here? We would randomly assign health insurance to some people and not give health insurance to other people, and we would compare their expenditures, compare their health outcomes, and so forth. Now, this turns out to be a rare case. Usually what I then say is, we can't run that experiment. Now here's a quasi-experimental design that approximates that. This turns out to be the rare case where we can actually look at exactly such an experiment. Such an experiment was actually conducted. And it was conducted in 2008 by the state of Oregon in what's come to be called the Oregon Health Insurance Experiment, where what happened was Oregon had the capacity to expand Medicaid insurance coverage to people between the ages of 19 and 64, so basically below the Medicare cutoff. They could cover more people than they were previously covering. However, they realized that the budget they had was not adequate to cover all the individuals who would be eligible under the expanded requirements for the policy. And so they did something unusual and something quite useful from the perspective of learning. They decided to offer insurance through a randomized lottery. So they took a set of people who were eligible. They said, you can apply for insurance. We're not going to be able to cover everyone. We're basically going to flip a coin. And some people who apply are going to get insurance, and some people who apply are not. And so they ended up working with a group of researchers at MIT and Harvard to design this in a way that, they were forced to do this because of budget constraints, but design it in a way that it would actually be useful for learning something from a scientific perspective. And so what happened was there was a treatment group of about 30,000 individuals who got Medicaid insurance as part of this program. And there was a control group randomly selected of 45,000 people who did not. And so what you can do, and what folks at MIT and Harvard and elsewhere did, is evaluate the impacts of this experiment using administrative data from the Medicaid program and hospitals, as well as various follow-up surveys. So it's a series of papers. The results I'm going to show you are from a series of papers written by Kate Baker, who was at the Harvard School of Public Health at the time, Amy Finkelstein at MIT, and a number of their collaborators. So before I show you the results, I want to have the class do a poll to just get a sense of what people think about the following question, which was one of the questions that was answered by this experiment. So do you think that providing health insurance is likely to increase or decrease the use of emergency rooms? So just to give you a bit of context, why is this an interesting question? One view was that by providing more health insurance, normally people without health insurance, they have acute illnesses, they end up in the emergency room. Maybe if we provide health insurance, they'd get more preventive care and they'd use the emergency room less. So that's one hypothesis that received quite a bit of attention. It was one of the arguments cited for expanding health insurance coverage, that it could actually save us money by having fewer people go to the ER. A different view is once you have health insurance, it now becomes less costly to go to the ER itself, and maybe people end up using the emergency room more. So it's an empirical question. Which do we think will happen? Do we think people will use the emergency room more when we provide more health insurance, or do we think they'll use it less? So let me see what you guys think. This was actually a very important point of debate before this study resolved the question. I'll give you guys a minute. Okay, so looks like most people think it will actually increase the use of the ER rather than decrease it. So I'll show you the data in a second. I will say, I think in the public opinion, especially people on the left who are advocating for expansion of health insurance, there was a strong sense that expanding health insurance would decrease emergency room use. That I think was a very widespread view. So we'll come back to look at that in a second in the data. All right, so I'm going to show you a series of results that are in bar charts like this. It's just a straight experiment, so we're just going to compare averages basically in the control group and the treatment group, but there are some complications related to what we've talked about in previous lectures. So there are issues of non-compliance. There are a bunch of people who were randomized into the treatment group who didn't actually end up getting the insurance for various reasons. They became ineligible, they didn't take it up, they didn't finish the paperwork. So you have to adjust for that non-compliance effect, which they're doing in the background here. And there's some other technicalities like that. So in the sections this week, we're going to go into those details in much greater details. We're going to talk about the methods of the study in much greater detail. And that will be important because in the next empirical exercise that you're going to do, the next empirical project, you're going to do something very analogous to this type of evaluation with the creating moves to opportunity data. So you'll want to follow that closely. Here I'm just going to summarize the bottom line results, and you can dig into the methods more by looking at the paper or talking about it in section. So what's being plotted here in the darker blue bars on the left are the control group averages for a variety of different outcomes. So did you have your cholesterol checked? Did you have a colonoscopy? Did you get a flu shot? Did you get a mammogram? And so forth. And then what's being plotted in the light blue bars is that control average plus the estimated treatment effect of the experiment. So this is essentially like the average that you see in the treatment group, but adjusted for the fact that you don't have 100% compliance rate. So you've got to scale up that treatment effect to adjust for that, as we talked about in one of the earlier lectures. So let's just take the first pair of bars as an example. You can see that in the control group, about 25% of people had their cholesterol checked. So among people who didn't get randomly assigned to getting health insurance, 25% got their cholesterol checked. You can see that that goes up to a little over 40% among the people who were randomly assigned to get Medicaid insurance. So note that the only treatment here is whether you get insurance or not, right? There's nothing that's directly getting you to go to the doctor. That's still your own choice. Do you decide to go to the doctor and have your cholesterol checked, what you can see here is a significantly larger fraction of people choose to go and get their cholesterol checked if they have health insurance relative to if they don't. That makes sense intuitively. The cost of going to the doctor has basically fallen, and so now you demand more of that service. So you see that pretty much across the board for these various outcomes. So if you look, for example, at the fraction of women who get mammograms, when you have health insurance, that nearly doubles from 30% in the control to 60% in the treatment group. So on a variety of measures of the use of preventive care, we see quite significant increases and significant improvements. Okay, so health insurance does seem to matter in the extent to which people are using preventive care. You can see that very clearly from this experiment. Okay, in a different dimension, you can think about diagnoses and medications for various conditions. So are people diagnosed as being diabetic, for example? Significantly higher rate that you get diagnosed as diabetic if you have health insurance relative to if you didn't. Why is that? Simple reason, you're more likely to go see the doctor if you have health insurance. They're more likely to identify that you have diabetes. You're more likely to get treatment for it. You're more likely to get prescriptions. That's the RX. DX is diagnosis. And you see that across the board, more likely to be diagnosed with a high cholesterol condition, more likely to get a drug like Lipitor, say, to treat that high cholesterol. And so similarly, in terms of mental health, in terms of hypertension, a variety of conditions are being identified more and being treated more. So people are using more healthcare. Health issues are being identified more frequently. Next, you can turn to this question of where that's happening and what types of healthcare are people using. So this was the poll question. What happens to emergency room use, emergency department use? And you can see that emergency department use actually goes up rather than down. So even though people are using more preventive care, it's not sort of adequate, such a big effect that it actually leads to lower emergency room usage. I think the way to think about it is that people just use more healthcare in general when the price is lower. They're more likely to go see the doctor for preventive care. They're also more likely to go see the doctor if they sprain their ankle or something like that. And so you end up in the ER, right? And so both in terms of whether you ever show up in the emergency room on the left or your number of visits to the emergency room on average, you see a significant increase. So I think that kind of hopeful scenario that people had, that expanding health insurance coverage would actually save us money by getting fewer people to the emergency room, unfortunately, that's not the case. That doesn't mean that it's still not a good idea. We're still seeing significant increases in use of preventive care, and maybe that's a good thing, you know, more generally, but the kind of extreme scenario where you're saving money on the ER doesn't seem to be happening. So then you get to the question of whether you're actually improving health outcomes from all this. So at the end of the day, you know, great that people are seeing the doctor more, getting more preventive care. We think that's all probably useful, but you know, ultimately the point of this whole thing is to try to improve people's health, right? And so what they did is used a series of follow-up surveys to try to actually assess people's health in the treatment group and the control group in various ways. So do you have elevated blood pressure? Do you have a high level of total cholesterol? Hemoglobin A1C, a measure that's relevant for diabetics? Do you screen positive for depression? So on all of these dimensions, if you look at the left 4 bars, so the vertical lines you're seeing there are 95% confidence intervals. And you can see that the dark blue and light blue bars are not significantly different from each other. So you see, you know, maybe a slight reduction in the fraction of people who report elevated blood pressure, but it's not statistically significant. The estimate could lie anywhere from the bottom of that black line to the top of that black line. And so we have no confidence really about whether there's been a significant reduction in the fraction of people who have elevated blood pressure. Now let me say 2 things about the interpretation of these results. So one exception to that pattern is the last set of results, as you can see, where there's a significant reduction in the fraction of people who screen positive for depression. So it does seem like there's a significant improvement in mental health as a result of provision of insurance, which is of course quite important in and of itself. Now, on the other dimensions, when this study was put out, and it got quite a bit of attention in the media, it was frequently reported as saying, Oregon Health Study shows that people use more healthcare, but there's no significant impact on health outcomes, things like blood pressure, cholesterol, and so forth. And that was kind of framed as saying, now we know expanding health insurance leads people to use more healthcare, but this is not actually that useful for health. So that is, I think, a misinterpretation of what these data show. What you should actually conclude from looking at this is that you don't have enough statistical precision to be able to really tell if you had significant impacts on these outcomes. Because it's quite possible, as you can see here, that we lowered the fraction of people who had high blood pressure by from something like 15% down to 9%, which would be like a 60% reduction in the rate of that problem, which would be a massive impact. And so, this is, I think, a very important lesson in terms of how to interpret statistical results. When you see a statistically insignificant result, you shouldn't confuse that with there's zero impact. The statistically insignificant result just means you didn't have enough information to tell. And if you have very wide confidence intervals, as you do here, all you can say is there's insufficient data to tell if there was a really big effect or a really small effect. Now, that's a nuance I think that's difficult to convey in the media in particular. And so this study got reported in a number of different ways where people were trying to use it to support, I think, sort of their prior views. But that is, I think, what you can actually tell from these data. On some dimensions, there's a clear improvement. On other dimensions, we just don't have enough data yet. And that's one of the challenges with experiments. Even if you have a relatively large sample, as they did here, trying to track impacts on things like health, there's a lot of variability in those outcomes, and you often, you need huge samples to figure things out. Questions on these results? Yeah. Yeah. So this, I think, was a year or two after provision of health insurance. And so I'm going to come back to your question in a more detailed way. I think what you're getting at, I assume, is some of these impacts might take time to emerge. And I'm going to show you some evidence from other studies where we do much longer term follow-ups and you start to see that sort of pattern. Good question. Yeah? Yep. So mortality is going to have even lower statistical power than these measures, right? Because in a typical kind of working age population, the fraction of people who die, fortunately, is extremely low. And so as a result, you need really enormous samples to detect effects on mortality. The fact that you're not even able to really detect anything on cholesterol suggests it's going to be hard in this experiment to look at impacts on mortality. But again, when I show you some results on impacts over time from a much bigger study, a quasi-experimental study, I'll show you some results on mortality in a second. Anybody else on this? Okay, so one last set of measures. So the stuff I was showing you until now was just focused on health. So health insurance does two things. It potentially increases your use of healthcare and improves your health outcomes. But importantly, it's also a financial product, right? The idea is that it's supposed to reduce financial hardship. If you get hit with a health shock, you get injured or whatever, we hope you get health treatment, but we also hope that you lose less money because you don't have to pay the bills if that happens. And so they also try to directly evaluate impacts on financial hardship. How much out-of-pocket spending did you have to do? Do you have any medical debt? Did you have to borrow or skip payments on bills like your rent or utility bills? And you can see on all of these measures, as you would expect, when you give somebody health insurance, they are less likely to have these sorts of financial problems. So independent of whatever is going on in the health dimension, as I think is quite intuitive, health insurance reduces the amount of financial risk that people face, and that in itself is potentially quite valuable. Okay, so what do you learn from the Oregon health insurance experiment? What are kind of the high-level takeaways related to the broader set of stuff we've been talking about? So my read of it is that I think we learned insurance coverage significantly increases the utilization of healthcare. It's not a massive effect, but it does increase the utilization of healthcare. People visit the doctor more, people visit the emergency room more. Insurance coverage also significantly reduces financial hardship. So it's valuable from that point of view. Insurance, coming back to the theme we've been focused on health inequality, it does improve self-reported health and in particular reduces clinical depression, which is very important. But there's, as I was emphasizing, insufficient statistical power to detect effects on physical measures of health. Whatever you conclude about those impacts, though, stepping back, I think you can probably conclude that provision of health insurance is insufficient to explain the large differences in health outcomes that we were seeing between people at the bottom of the income distribution and people at the top of the income distribution. So the fact that low-income people live 10 to 15 years shorter lives than people at the highest end of the income distribution, I think if you take these estimates and were to try to gauge what the mortality impacts would be, you'd explain a small fraction of that variation, which is very consistent with the themes that have emerged from the previous lectures, that a lot of this gap appears to be about behavior rather than fundamentally about access to healthcare or access to food, et cetera. I think it broadly fits with exactly that set of lessons, all right? So what I'm gonna do next now is turn to basically address the question you asked on the longer term impacts of health insurance. So the Oregon experiment basically evaluates the immediate impact of health insurance coverage within a year or two. But as we've talked about in other contexts, for instance, earnings or college attendance rates, we think that many of these policies potentially have impacts that show up with a delay. So maybe if I give you health insurance coverage and provide better health care when you are young, downstream that will have payoffs in terms of much better outcomes later on. And so the specific question I'm going to turn to next is whether providing Medicaid, so the same health insurance program targeted at lower income families, does that improve long-term outcomes and potentially lower long-run costs, maybe by reducing hospitalizations or reducing emergency room use, the same kind of theme that we talked about before, which didn't seem to happen in the short run, but perhaps that happens over time. So here we're going to turn to a different study and a different methodology, a quasi-experimental regression discontinuity design, rather than the randomized experiment. So in a series of papers, Laura Wary and Bruce Meyer study these questions using a regression discontinuity design. What's the source of that variation? Turns out that Medicaid eligibility was expanded for children in low-income families. So they basically raised the income cutoff below which you were eligible for Medicaid coverage in a very interesting way. So in the late 1980s, Congress passed legislation that expanded Medicaid coverage, but depending upon the birth date of your kid. So it was expanded for kids born after September 30th, 1983, but not for kids born before September 30th, 1983. Okay, so that creates a sharp cutoff where if you happen to be born on September 29th, you are not going to get additional health insurance coverage while you're growing up. And if I was born on October 1st, I am going to get that additional health insurance coverage. And based on the simple intuition that people born on October 1st and September 29th are probably pretty similar to each other, we essentially have an experiment here, right? This is the logic of regression discontinuity that we've talked about before. So they use, again, administrative data, big data that's really useful to analyze things like this. In this case, they use discharge level hospital data and outpatient emergency department data from the states of California, Texas, New York, and a couple of other large states. Now, one limitation of the data they're working with, these hospital records, is that they don't have direct measures on income. So ideally what you would do is you'd have, say from the tax records, information on people's incomes, and you'd be able to hone in on the set of people who are now eligible for Medicaid, look at people with kids born just before versus after September 30th, 1983, and use that for your analysis. So lacking income data, they need some way to kind of isolate the population that's relevant for this analysis. You can't include everyone because you've got tons of middle income and higher income people who are unaffected by this program. So what they do instead to kind of get something that's correlated with income is cut the data by race. So as we've talked about in earlier lectures, race is a strong predictor of income in America. There are large racial disparities in income. And in particular, Black Americans, there's a larger fraction of Black Americans who are low income than white Americans. So race ends up being something that you can cut on that's going to be useful in this analysis. So I'm going to show you a set of graphs that look like this from their paper. The left column pools all races. The second column is for Blacks. This is kind of the population that they think of as the most heavily treated group, the lower income population. And then the right column is non-Blacks. What they're doing first is just plotting the fraction of kids who have Medicaid coverage, who have health insurance coverage, between the ages of 8 and 13 by the month in which they are born. Okay, so this is the first step in the analysis, just showing that there's sort of an experiment here, the first stage of the analysis. So on the left, you can see when you're pooling races, all races, 0 here denotes September 30th, 1983. So that's like the cutoff. To the right of that, kids born after September 30th. To the left of that, kids born before. And you can see that there's a jump in the fraction of people who have health insurance coverage among those born just after versus just before. And that's particularly clear now if you look at the middle chart, look at Blacks, you see that the fraction of kids who have health insurance coverage jumps by something like 7 percentage points to the right relative to the left. Why does it jump by only 7 percentage points? Because remember, you're including everyone here, not just the people who are on the cusp of Medicaid eligibility. So there are going to be lots of people who have private health insurance, lots of people who don't qualify for Medicaid. So that's why it's not going to jump anywhere from like 0 to 100%, right? But clearly there's some impact there. There's some break there, so you have a quasi-experiment that you can study. Now, if you look at non-Blacks in the third panel, that basically doesn't jump at all from the left to the right. And so that serves as sort of a control group where nothing is really changing around September 30th. So what is the assumption that they're going to make underlying this analysis? They're going to make the standard regression discontinuity assumption that you guys have now studied a fair bit, which is that the people just on the right of the cutoff are similar to the people just to the left of the cutoff, that there isn't anything else changing sharply around that point. And they show that various attributes of families look relatively balanced, similar on the left and the right, as you'd expect intuitively, right? There's no particular reason to think that something dramatic would have changed one day after versus before in terms of kids' birth dates. Okay, so that's the setup. So what we can then do is now coming to answer your question on longer term impacts, you can look at outcomes much later on. So this is now looking at hospitalizations in 2009. So think of this as like something like 20 years after the insurance coverage was expanded. And you see, I think, a pretty cool and striking result, which is if you look at the fraction of kids who are hospitalized, look at the middle panel, which for Blacks, which we really think of as the treatment group here, you can see very clearly that there's a significant reduction of about 10%, 0.1 log points in the fraction of kids who are hospitalized among those who were born on October 1st rather than September 29th. So it really seems like there's a causal effect of getting health insurance when you were a kid on your probability of being hospitalized when you're much older, right? So there's a lasting impact of these programs. You can look at other measures, so being hospitalized for a chronic illness, you see a really sharp reduction there for Blacks on the left relative to the right. If you look in contrast for non-Blacks, there's basically no break at that cutoff, consistent with the view that this is a control group. There was no break in insurance coverage at that point either. So it really seems like this is working through the causal effect of the insurance. You can now come back then to the question of the emergency department visits, which we talked about before. And here you see a very different pattern relative to what we saw before, where increasing insurance coverage led to more emergency department use at the same point in time. Here we're seeing if you were more likely to be insured as a kid, you are less likely to use the emergency department when you're an adult. So the long-term impact is extremely different. What the mechanism here is also very different, right? It's not that we're changing the price of healthcare at the current point in time. We're providing better healthcare while you're growing up, which is improving your health, which is leading you to be less likely to end up in the emergency room when you're older, right? And so again, you see those effects very clearly in the middle, but you hardly see any break on the right. So I think that's extremely compelling evidence of long-term impacts of health insurance and healthcare provision on health outcomes. And then finally, coming to your question on mortality rates. So this, you'll see, first of all, these graphs look much noisier than the graphs I was showing you before. So that goes to the point that I was saying earlier, that there's a lot more noise in mortality data. Not many people die, fortunately, in their 20s and 30s. And so that's why you don't have a ton of precision here. Nevertheless, I think if you look carefully at these pictures on the right, for Blacks, you can see that there are significantly lower mortality rates on the right relative to the left. So it does seem like getting more health insurance coverage, healthcare when you were a child, is reducing mortality rates at older ages as well. Okay, so on a number of dimensions, we see these long-lasting health impacts. So any questions about this study? Anyone? Okay. Now, let me make one final point on that. So what I was showing you here is mortality rates for what are called internal causes. So these are things like getting a respiratory disease or cancer. That would be an internal cause. A nice additional check they do is you can replicate the same thing for what are called external causes, getting in a car accident, drowning, things like that. And you can see that there's no break in mortality due to external causes, which makes sense, right? Like, why would having health insurance as a kid change your chance of getting into a car accident when you're 16? It's all driven by internal causes. So I think I find this a quite compelling set of evidence that we should really think about health insurance as having long-term impacts rather than short-term impacts. Very much in the theme of a lot of the things we've talked about in this class, where we think about environment really having impacts accumulated over many years as opposed to at a given point in time. It's very consistent with that sort of exposure view. Okay, so what's the takeaway from the set of studies we've talked about so far? Health insurance coverage leads to moderate increases in healthcare use and improvement in health outcomes, especially in the long run. So my take from that is increasing access to health insurance can potentially be pretty valuable for improving population health. It still may not close the full gap in life expectancy between low-income and high-income Americans, but especially if you do it at younger ages and it accumulates over time, I think you can have a pretty significant impact, both through the provision of healthcare and perhaps by changing people's behaviors down the road as well. That said, if you now come back to the economics of this, like let's say we've established that health insurance and healthcare is really useful in terms of improving health, it does not necessarily follow that the government needs to provide that insurance, right? So in the same way that we think that, you know, having an iPhone or having a car is useful for you, it doesn't necessarily automatically follow that the government needs to be involved in providing that iPhone or that car, right? So why is it that in the case of healthcare, we don't just leave it to the private market and say, health insurance seems to be useful, great, just like people can buy any number of other things, firms will set up to sell health insurance and let's let people buy healthcare on their own. Why do we bother with the government coming in and either trying to provide healthcare directly or intervene in health insurance markets through something like Obamacare, where there's a mandate, or a universal healthcare type of program? So what I'm going to turn to next is answering that question. There's a long literature trying to study this question. I'm going to talk about one recent study that I think nicely captures, using modern data, why government intervention can actually be sensible. So this is a paper, again, by Amy Finkelstein at MIT and Nathan Hendren and Mark Shepard, who are my colleagues here at Harvard, And here they show why government intervention is actually quite essential to sustain markets for health insurance in a way that speaks very directly to current debates in this policy space. So what they do is study the Massachusetts public universal health insurance program, so at the time was called Romney Care, introduced in 2006. It was basically the predecessor to the National Affordable Care Act. So the research design here is again going to be regression discontinuity. They're going to exploit discontinuities in the subsidies for insurance that are based on your income level. So the amount of money the government gives you to buy health insurance varies depending upon your income level in the following way. So if your income is extremely low, below 150% of the federal poverty line, so 1.5 times the federal poverty line, you don't have to pay anything at all for health insurance, okay? $0 out of pocket, Massachusetts will just cover your health insurance for you. If you're between 150 and twice the federal poverty line, you have to pay $39 a month for health insurance. If you're then between 2 and 2.5, you have to pay $77 a month. If you're between 2.5 and 3, you have to pay $116 a month. So basically, they're trying to target the limited subsidy dollars they had at the lowest income people living in Massachusetts, which makes sense intuitively. They implemented that with a series of cutoffs like this, which turns out to be very useful from a research perspective, because again, you can compare the person who was just above one of these cutoffs to somebody just below one of these cutoffs. So the first thing they do is just look at how this affects demand for healthcare. So this chart is a very simple chart that just plots the number of people who have health insurance by income level relative to the federal poverty line. So the same exact cutoffs that I was showing you on the previous slide. How many people are there who have health insurance in each of these buckets in Massachusetts after this policy was enacted in 2006? And you can see a very clear pattern, which is that it jumps down at every one of these cutoffs as the price is going up, right? So when you go from just below 150% of the poverty line to just above, the fraction of people who are getting health insurance falls by about 25%, from about 4,000 people to about 3,000 people. And similarly at all of these other cutoffs. So basically what this is telling you is a simple and intuitive result that demand curves slope downward. When prices go up for something, people buy less of it, right? And you're seeing that very clearly here in the context of health insurance. So to see the magnitudes of that, as I was saying, about a 25% effect at that first cutoff, and then similar percentage effects at each of the other cutoffs as well. So quite a substantial reduction. Yeah, question? A number of people. Yeah. So good question. I mean, you want to make sure you're kind of, the total number of people is not changing, because you want to sort of be dividing by that, right? Right around the cutoff, the number of people is going to be very similar on the left and the right. More generally, there are going to be fewer people in some parts of the data than others, but it's the same sort of standard assumption. As long as the number of people just to the left and just to the right who are eligible is not changing significantly, it's not going to matter. And they show with other data that that's basically the case. The reason that's a little bit tricky to do directly, you might ask, like, why don't they just show the percentages to begin with, right? Divide by the number eligible. Estimating the number eligible is actually not that easy, because you don't directly have that in the data, right? You need to kind of have a sense of who meets all the eligibility criteria in Massachusetts by income level. So that's why they just start with sort of the numerator of that ratio and then show that the denominator is not jumping at those cutoffs. That make sense? Yeah.
Why is there a negative slope in between intervals?
Yeah, it's a good question. I mean, I think that's sort of like a selection pattern. So, one potential explanation is as you're moving up in the income distribution, you're more likely to have private health insurance coverage, or your spouse might have health insurance coverage or something like that. So it speaks to the general point that I think is an important broader lesson, that you really should only focus on the discontinuities. Any of the broader patterns are driven by numerous confounds, right? And so that's the power of the regression discontinuity, that we're able to pull out the causal effect right at those cutoffs. Others? Yeah. Speak up. Yeah, good question. So you would worry in this kind of setting that if I know I can get a cheaper price for health insurance, just to restate the question, I might want to get my income below the 1.5 cutoff so that I can save money on health insurance. So they look in the data, that you can assess that in the data by basically seeing, if you look at the income distribution, does it look like there's more mass in the income distribution just below 150 relative to just above, right? In fact, you don't end up seeing that, which is encouraging. Why do you not end up seeing that? I think there are two reasons. First of all, remember that the price is changing by $40 a month to the left versus the right. So it's not a small amount of money, but if you think about what it would take to change your income by a little bit, right? So like imagine you're working at Walmart, working a certain number of hours. To manipulate your income like that to become eligible for this is actually not that simple. You'd have to somehow change exactly how your job is structured, number of hours you're working, and things like that. And so I think it's plausible, given those kinds of adjustment costs, that people don't actually respond. But you're exactly right, like that's the type of concern you'd potentially have with this study. Okay, so we see that people buy less health insurance as the price goes up. We can turn that into a demand curve. So I like this figure because those of you who've taken an introductory econ class, you see kind of the hypothetical demand curve that's drawn out. As you vary prices on the vertical axis, what happens to quantities, the fraction of people buying the product. And this is a real world demand curve for health insurance that they've estimated using those cutoffs. So they're basically plotting each of those points, right? So at a price of $116 per month, 44% of people buy health insurance. If that price is dropped to $77, the fraction who buy jumps up to 58%, and then so forth and so on in each of the cutoffs that they estimate. And if you kind of stitch that together, you get this very nice demand curve. As you reduce prices, what happens to the fraction of people who are buying? And what you see when you look at it like this is that the way economists would say it is that the demand for health insurance is very price elastic. That is, price matters a lot. When you vary the price from 0, at which point 95% of people buy health insurance, like why would you not take something that's free, to a price of $116 a month, the fraction who buy drops to 44%, right? So you wipe out like more than 50% of the market by raising the price from 0 to about $100 a month. So people are quite sensitive to price, which I think makes sense, especially in a low-income population. Paying $100 a month for health insurance, if you feel like you might not use it that much, you feel like you're healthy and so forth, makes sense that you might not want to pay for this, right? And so what is the implication of that? So we see that the demand for health insurance among the poor falls very rapidly as price rises. The implication of that is that if we were to reduce subsidies, we would drastically reduce the number of individuals who are insured. If you kind of leave it up to people and leave it up to private markets and there's some charge for health insurance, lots of low-income people are just not going to buy health insurance. That's what you see clearly from this data. So that, is potentially a concern in and of itself. If you as the policymaker think it's very important for everybody to have health insurance, for everybody to have, maybe because you care about health outcomes directly or something like that. But it's actually not, I think, an adequate justification by itself to justify government intervention, because there are lots of things that people might not buy if prices are higher, right? So if the prices of iPhones are extremely high, lots of low-income people might not buy iPhones. But it's not like we feel like the government should come in and do something to make sure everybody can get an iPhone, right? So why is it in the context of health in particular that we're worried about lots of people not buying health insurance? So the second key thing to note that they demonstrate nicely in this study is that the people who are not buying health insurance are not just a random set of people, but a particular set of people. So in particular, sicker people choose to remain insured as prices go up, which increases the average costs for insurers. And that leads to a very important phenomenon called adverse selection that economists have talked about in theoretical terms going back to the 1970s, starting with some famous work by George Akerlof. And they demonstrate how that plays out in the data in a way that can really affect how this market functions. So let me show you how that looks in the data by coming back to the same chart here. But now, instead of plotting the fraction of people who are buying health insurance, look at the average cost paid by insurance companies for the people whom they are insuring. So remember, as you move to the right of each of these cutoffs, a bunch of people are dropping out of the market. All right? A bunch of people are deciding they don't want to buy health insurance anymore at this higher price. What you can see is among the people who are still left, the average amount that the insurance company is paying for their medical expenses is significantly higher. So what is that? What's going on there? Basically, the healthier people, like if I know I'm perfectly healthy, I'm never going to use my health insurance, never going to go see the doctor, then when you raise the price from $0 to $39 a month, I decide I don't want to buy health insurance anymore. But the types of people who drop out are the healthier people. So the people who are left are people who know they have some pre-existing medical condition, they tend to go see the doctor more, and so that ends up basically increasing costs for the insurance company as you have people drop out at each of these cutoffs, okay? So you're left with a sicker population, basically, as prices rise. That's what's called adverse selection. You're adversely selecting from the pool of people. You're selecting people who are going to cost the insurance company more. All right, so so now why does that potentially create a rationale for government intervention? Let's just walk through the logic of this given these two findings. So what these two findings imply is that government intervention is likely to be critical to sustain markets for health insurance for two reasons. First, as we saw initially, low-income individuals are very sensitive to price, so they will not buy insurance if it's not subsidized or directly provided by the government. But then second, and perhaps more importantly, the healthiest low-income individuals are least likely to buy in a private market where prices might be high. And so what that's going to end up doing is that insurance companies get stuck with higher costs. They get stuck with this pool of sicker individuals, and that can potentially make the market collapse completely. So, concretely, adverse selection can lead to what people call a death spiral in private insurance markets, where, intuitively the way to think about it is you start out providing health insurance to a bunch of people at a certain price. Let's say it's $200 a month. A bunch of the healthiest people say, I don't want to pay $200 a month because I don't think I'm going to go see the doctor that much, so I'm not going to buy health insurance anymore. Okay, so the insurance company then says, okay, so now I'm left with like 90% of the people I had before, but I'm left with a sicker 90%. So my costs now are more than $200 a month. I have to raise the premium up to $250 a month to cover the fact that the 90% of people I have left are sicker on average. So now when you raise the price to $250, there's a next set of people who are not the healthiest, but the next healthiest group of people, and they say at a price of $250, it's not worth it for me to buy health insurance. So I'm going to drop out. But now this process repeats itself, and the insurance company finds itself again with a sicker population, having to raise prices further, and this goes on until the market can completely collapse. So basically what's happening here is because there's what's called asymmetric information, people know more about their health status than the insurer can't correctly price the product, so you keep adversely selecting the population, and you're not able to sustain the market. So Akerlof and other economists demonstrated this as a theoretical possibility. This was extremely influential. George Akerlof, one of the most influential economists last century, won the Nobel Prize for this and other related work. More recently, we have seen that this is not just a theoretical phenomenon, it's actually empirically relevant. Turns out actually one of the famous studies on this was by my colleague in the econ department, David Cutler, who studied health insurance plans at Harvard itself. Turned out Harvard tried to do something like this, provide a variety of health insurance plans for its employees, and they document very clearly how in the late 1990s there was exactly this death spiral in the Harvard health insurance programs where people started opting out of the higher up, the greater coverage health insurance plans, and they basically collapsed over time. They weren't able to sustain it. The revenues they were bringing in didn't match the costs. And so putting that together, what you learn from this is if you just leave it to private markets to provide health insurance, it's very different from the private market for cars or iPhones. The market for health insurance, because of the nature of health demand, because of the asymmetric information problem, may actually collapse completely. And so Nathan Hendren, has a quote in the New York Times where he says that Trump Care, that is basically eliminating the mandate. There was a lot of discussion, you might remember, about eliminating the penalty if you didn't buy health insurance. So he says, based on the results of the study, that that would effectively end enrollment in insurance markets for families that make less than $75,000 a year. And so that study was then, prominently discussed when it came out in 2017 and played, part of the role. I think this is part of the reason that actually changing Obamacare is so complicated. Doing small things that you might think of as like a tweak, like we're going to get rid of that penalty, could end up completely changing what this market looks like. And so I think this gives you a sense of why, from an economic perspective, government intervention in the healthcare setting might actually be essential. If not in this particular way that we're doing it in the United States, it makes sense that more broadly in countries around the world, that healthcare is something in which governments are involved. Okay. Questions on this work? All right. So I'm now going to shift gears in the rest of the class and talk about a very different set of stuff, methodologically and in terms of topic, which is more from epidemiology and public health than economics. Okay, so the large fields of public health and epidemiology, what do? They focus on improving health, thinking less about incentives and insurance like economists tend to do, and more about how you change either individual behaviors, so a lot of focus, for instance, on how you reduce rates of smoking, for example, or increased rates of exercise, public health campaigns, things like that. Or what we're going to focus on here, improving population health, for instance, through the provision of public goods, so like a lot of traditional work on improving water quality or air quality, or reducing the spread of contagious diseases. So what I'm going to do here is give you one example of how big data is starting to enter this field as well. It's very early stage, like within the past 5-7 years, by focusing on one classic question in this area, which is forecasting and preventing health pandemics. So as you all know, contagious diseases like the flu spread exponentially. So, if you've got one person, then 2 people, 4 people, that compounds and then soon it's out of control. So there are large returns to taking action very quickly when a disease emerges. If you can find sort of the hot spot where something is starting to emerge and treat people there, it can be much, much more effective than if you wait and let it spread much further and you have a much larger number of people to deal with. So given that, there's a lot of interest in monitoring the spread of diseases and doing so in a very local way, in a very high-frequency way. The most common method to monitor the spread of contagious diseases in developed countries traditionally is using aggregated data from local clinics. So there's basically a reporting system set up such that you go to see the doctor at your clinic, doctor figures out that you have the flu, that gets reported with some delay to the CDC. That data gets aggregated across all the clinics in the United States, and now we have an index of the prevalence of flu across the country that's constructed week by week. So that works. The problem with it is one that it's relatively slow reporting. So ideally, you'd be able to pick up very quickly on the same day or a day later how the flu is spreading. Naturally, you can see, given the system I just described, there are going to be some lags in that process. And second, you end up with small samples, especially if you're looking at local areas. There might only be a couple of clinics. You don't have a ton of data in each place. So the data tends not to be very fine-grained. If you look at news media reports about the spread of the flu, they'll often be at the state or regional level, and there's less, very local data like what's going on in different parts of Boston, for example, which you can imagine would be quite useful. So how can you try to address this problem with modern data? So there's a very widely cited paper in Nature by Ginsberg et al. In 2009 that proposes a new data source to monitor the spread of the flu, which is Google search data. So what's the idea? It's very simple in terms of the basic logic. When people get sick, they often search for terms like antibiotics or how to treat a cough. They type that in Google. And so the idea is that you can use aggregated search query data to get predictions about the spread of the flu that are A, more timely, because you can get the Google search data immediately, basically in real time. And second, you can potentially get it at very fine geographies because you have big enough samples. You can see that people are searching for something in this area versus that area with quite a bit of volume. So what's the simple logic of this? If you can show that searches for antibiotics, for example, are correlated with the actual spread of the flu using the CDC data, you can then basically construct an index of the spread of the flu based on rates of searches for the word antibiotics. Now, obviously, it's not going to work that simply because people search for antibiotics for many things besides the flu. So you're not going to find like a one-for-one correspondence like that, which is what makes this a statistically interesting and somewhat complex problem. And that's the methodology we're going to talk about here. Okay, so the method that we're going to discuss is predictive modeling. More broadly, this is the field of machine learning, which receives a lot of attention nowadays and is at the core of a lot of what tech companies are doing. It's the frontier of a lot of research and statistics. So in this lecture, I'm going to talk about simple, you can think of it as like simple versions of machine learning models, predictive modeling. And then in the next lecture, in the context of a criminology application, we're going to talk in more detail about machine learning methods. So these are completely distinct from the types of methods we've been talking about so far in this class, which are mostly oriented around causal inference. So here, the problem is not one of causal inference, right? We obviously don't think that the Google search data is causing the flu. We're just purely interested in prediction. We're just trying to find a predictor. We don't care what causes what for this particular application. And so how are they going to proceed here? So first, they get historical data on the truth from the CDC. So we've got this traditional measure of how many people have the flu that we're going to get from the CDC. We're going to treat that as the true data, not worry about any measurement issues with that, just treat that as valid data. So this is how these machine learning methods usually work. You start out with what people call a training data set. You start out with a data set where you've got some ground truth, and you're going to build a model to predict that truth, and then you're going to evaluate the various properties of that model. Okay, so in this case, they're going to estimate a statistical model using Google search data to predict the CDC data. They then evaluate the model using future data that was not used to build the predictive model in order to evaluate its accuracy out of sample. So these two steps that I've described here are really the fundamental logic of all machine learning applications. Step one is training. Step two is assessment of model fit or evaluation. Okay, and you're going to see in more detail various versions of basically doing those two steps. Everybody clear on what we're going after here? Okay. So getting into the specifics. So the data that they're going to try to predict are 1,152 observations from the CDC collected in the way that I described on flu incidence. These are weekly data from 9 regions of the US, so it's relatively coarse, like I was saying, from 2004 to 2007. The data they use, so think of that like if you're thinking about like a regression context we've talked about before, that's the left-hand side variable, the variable you're trying to predict. The right-hand side variables are counts of Google search data. So they have weekly data on Google search counts for 50 million terms by state from 2004 to 2007. Now, this, as you can see, just given the numbers that I put up on the previous slide, is an example of a very wide data set. If you think about each row of the data as being one of the observations region by week, you have 1,152 rows in this data set, so 1,152 outcomes that you're trying to predict, but you've got 50 million variables. You've got the number of times people search for antibiotics and cars and specific types of cars and every other word, right? 50 million words. And so we've been talking about in this class lots of long data sets like tax records where we have a ton of observations relative to the number of variables. And that's very useful in causal inference. In the context of prediction, it's very useful to have lots of predictors in order to predict the number of observations you have. Now here they have relatively few observations, 1,150, but even if you had 1 million observations, you'd have relatively few observations compared to the number of variables you have, right? So that's kind of the fundamental setup that computer scientists and statisticians tend to focus on nowadays in the machine learning context, where you have many, many more potential variables to use for a prediction than you do number of outcomes. So why is that focus on wide data? Why is it important to think about that carefully? It's because it leads to a problem that is called overfitting, which is that you can basically fit the data perfectly using 1,152 explanatory variables. And that means that you can't use traditional statistical methods like the ones we've been talking about in this class so far, like regression, for example. They are not going to work in this context. So let me try to say in simpler terms what the overfitting problem is. If I give you, let's say 10 data points, and I give you hundreds of variables to predict those 10 data points, you're going to be able to pick any 10 variables to predict the 10 data points that I give you perfectly. You'll have a perfect model that explains that data. Now, the problem with that is you haven't really learned anything that's potentially useful to make future predictions, right? Our goal is not to try to predict what happened in the past, but to build a model that will predict well what happens in the future, what's going to happen in terms of rates of flu. And if I just pick any 10 random variables and construct a model that happens to perfectly fit the data that I have, there's no guarantee, and in fact there are results in this literature that show that in general such a model will perform very poorly in predicting future things outside the sample that you're working with. Basically the problem is that you've got too much information that you're trying to use to predict a small set of stuff, and that leads you to overfit the observations that you have in a way that doesn't yield a model that is stable and useful in terms of making broader predictions outside the specific sample you're working with, okay? So the way you solve this problem in this literature is using what's called out-of-sample validation. The idea is really quite simple. You basically split your data into multiple parts. So if I gave you 1,000 observations, I use 500 for the training phase and then 500 for out-of-sample validation so that I estimate the model on one set of data and then I evaluate its accuracy on a totally different set of data. So I kind of pretend that I didn't have the data, let's say in 2007, build my model using data from 2006, and then see if it works using the data from 2007. And you kind of do that iterative process to get a model that is not overfit, that actually works for out-of-sample predictions that you care about. Okay, so what I'm going to walk you through is, in a little bit more detail, how they actually go about doing that in this paper. Okay, so they're going to construct a predictive model in a series of steps. First, they take each of the 50 million search queries, call them Q, separately, and run a simple regression of the CDC data on that term. Okay, so what this equation is I of t, think of that as the number of people who have the flu in a given region at a given time t. Q of t is the number of search queries for a given term in that region in that period. So it could be like, how many people searched for antibiotics? How many people searched for cough? So you'd have a count for each of these terms. And for each one of those 50 million terms, you just basically, it's a simple regression or like a correlation between influenza rates and the rate of that search query, okay? You then calculate the correlation between the predictions from this very simple regression model and the true CDC data across the 9 regions. So sorry, let me just be clear. So in the first equation there, they're using the aggregated national data and just trying to predict the national trends. And then they're saying, I now have this data separately for each region. I'm going to correlate the predicted values that I get from that model, what I predict the flu rates will be, with the actual CDC data that I have for each of the 9 regions in the sample that I have, okay? So now I can construct this correlation for each of the terms in my data set, antibiotic, cough, whatever else, and rank the 50 million terms based on how large that correlation is. So basically, something like antibiotics, I'm going to find a pretty high correlation with rates of the flu as measured by the CDC. Something like totally different, like cars, presumably I'm not going to find a very high correlation. So I'm just going to sort the data based on the strength of those correlations for all 50 million terms, okay? And what you end up finding is that it includes some intuitive terms like I've been emphasizing, like cough and antibiotics. It also includes some less intuitive terms like high school basketball. Why is high school basketball really correlated with the flu? Because the flu tends to occur at a certain season, which is correlated with when there's a lot of high school basketball games, okay? And so those two things end up correlating with each other. Now, you might think like, that's kind of weird, like why would I want to use that? But this is where the distinction between prediction and causal inference is really important. Suppose it turns out that high school basketball is a perfect predictor of the flu, like great, we should just use that possibly, right? I mean, that's kind of irrelevant for the perspective of this question. It also includes some things that at least to me make less sense, like Oscar nominations, but maybe there's also some seasonal effect there, but that also turns out to be a strong correlate of the flu data. Okay, so that's the first step. That's kind of the training phase, all right? So then they're going to use a separate set of data from later weeks to decide which of the top 100 terms in terms of these correlations to include in their final prediction model. So basically, they're going to construct the sum of search queries across the top n terms. So take the first term, the first 2 terms, the first 3 terms, and so on, and evaluate how well that sum predicts both the regional and weekly variation in a new sample. This is critical, not using the data they used before, using a different subsample of their data, varying n from 1 to 100. And so to show you what you get from that exercise, they have this plot here which shows the number of search queries that they're going to use. Just the first most highly correlated search query, let's say that's cough, then adding in the second most correlated one, the third most correlated one, and so forth. And they're going to pick as you add more and more queries in this new data, they're going to pick the number of queries that maximizes the model fit, that maximizes the correlation between their predictions and the actual data on flu outbreaks. And you can see that that happens here when you use 45 queries, okay? Turns out when you use 45 search terms, you maximize your predictive power. If you use more than that, if you start to use 100 terms, like you might think, oh, more data the better, right? But that's actually not true, and that's what the overfitting problem is about. If you start to include lots of terms, you include, like when you see that sharp drop, they're including the term Oscar nominations there, and the correlation actually drops pretty sharply because that so happens to be a variable that was correlated in the initial sample they were working with, but when you then take the model to a new set of data, it doesn't actually help you to add those additional queries. Okay, so in the second step, they picked this 45 queries to focus on. And then finally, in the third step, they evaluate model fit and out-of-sample predictive accuracy using a third entirely different set of data that was not available when the model was estimated. And so just to show you how that works, this is kind of the bottom line from the exercise. The CDC's official statistics on flu outbreaks at the national level are shown in red. And so you can see that there's spikes in different years. 2004 was a particularly bad year in terms of the flu. 2005 was better, and so forth. They fit their model using the technique that I described, using data up to 2007. They did not have data after 2007 when they estimated their model. And then they show in 2008 that their prediction off of the Google search data in the black, you can see almost perfectly fits what actually happened in 2008, which is pretty cool. They built this model that exactly matched what the CDC could do using this technique. So I'm going to stop here. In the next lecture, we'll talk about how you refine this method and some pitfalls with this approach. So we're going to continue talking about, just wrap up on health, the final bit of stuff on the Google prediction model that we were talking about at the end of the last lecture. And then I'm going to talk about a related set of methodological issues, talking about machine learning applications to crime and criminal justice. So to remind you where we left off, I don't know what happened to this slide. This is on the, okay, let's just, here we go. Okay, that's odd. All right, so we ended with this graph here, just to recap what we're doing here. So we're trying to predict flu trends. The official data from the CDC are in the red. And then we talked about how Ginsberg et al. In this paper published in 2009 built a simple machine learning prediction model using Google search query data to forecast those trends. And just to refresh your memory on the 3 steps involved in constructing those forecasts, first they correlate each of 50 million different search terms with the data from the CDC on actual flu incidents using data from clinics. They then figure out how many of the top search queries to use, and they settle on something like 45 search queries as the optimal prediction model based on an out-of-sample validation technique. And then in this third step, which is being illustrated here, they're showing how their forecast compares with the actual data. So the Google Trends forecast is in black, the CDC data is in red, and then the true out-of-sample validation here, kind of the test of their model, is shown after the dashed line. They use data only up to 2007 in their analysis, and they show that they forecast very well what trends look like after that point. So I think that's a nice illustration of how these types of machine learning methods can potentially be very useful in the context of prediction. Now, to show you a little bit further why this can be so valuable, so it's not just that you can match the CDC data at kind of an aggregate level. What you can then do, so what's the advantage of using the Google search data? You can do things at a higher frequency, so you can get data more quickly, and you can also get it at finer geographies. So illustrating that first point here, what they're doing here is, again, showing the CDC official statistics in red, and then at each point, they're showing what the Google forecast was going 2 weeks beyond that, right? So when they had data available up to February 4th, 2008, you can see what they forecast. They forecasted an uptick in the coming 2 weeks before CDC actually put out that data. And then if you go down to the second panel, you can see they were exactly right about that, basically. There was an uptick, in fact, when you have the red series going up to March 3rd. You can do the same exercise again. They're predicting a decline in the next couple of weeks after that. That's in fact pretty much exactly what happens. See that in the third panel. And then again in the fourth panel where they're predicting that it's going to come down even more, and the CDC data matches that. So you can see that as a leading indicator, before the CDC is able to release these statistics, the Google Flu Trends forecaster is actually working quite well. Now, that I think seems like a real success, but there's also kind of a parable in this in terms of how these things sometimes don't work. And so it turns out this Google Flu Trends predictive model broke down in late 2012 and became very inaccurate in forecasting outbreaks of the flu. So there's a subsequent paper in Science by Laser et al. In 2014 that documents the model's failure by essentially extending the window used for out-of-sample validation a few years further. So they take that same prediction model that the previous researchers built, and they basically ask, how well is this thing doing a few years in? And what you can see here is, as I was showing, in the earlier data, if you look at 2009, 2010, 2011, the Google flu data and the CDC data match each other very closely. But then if you look at what happens in 2012, the 2012 flu season, the Google estimates are more than double what CDC actually reports in terms of flu incidence. So something has gone wrong with the prediction model. It no longer matches the actual data. And so, what exactly happened? Why did the model start to perform so poorly? It's basically a change in the underlying technology of the platform. So Google search engine, those of you who've been using Google for a few years might remember this, it started to prompt users to search for additional diagnoses after entering a term like fever or cough. So basically, they put in the autofill feature, which changed what people were searching for, because if you type cough, it now suggests other things that you might add to that based on common searches. And so those changes in the underlying setup of the system changed the nature of the search queries, which then, if you're using the same prediction model that you were using before, that you estimated in kind of the old regime, you're now going to get predictions that are inaccurate if you don't re-estimate the model and sort of start over. Okay, so you can see how these types of things, these machine learning models, can be very susceptible to changes in the underlying environment. You can potentially get predictions that are quite far off. There's obviously no guarantee that the prediction is going to be totally stable over time, especially when you're changing the platform. Okay, so what do I think you learn more generally from this Google Flu predictive model beyond this particular application? So I think it illustrates, and this paper and this type of work has sparked a great deal of interest in predictive modeling with applications to social problems. So Ginsberg et al. Became the basis for a tool called Google Correlate, which is a publicly available tool to find searches that correlate with real world data. And now, in fact, our research team is working more broadly with Google to try to construct leading indicators of economic and social variables like flu trends, but thinking about it in the context of segregation, upward mobility, creating forecasts that cities and governments might be able to use to take action more quickly. So I think this is an incredibly valuable area for further work. Second, though, as a caveat, I think a lot of people think of big data and machine learning as sort of, this is going to be the solution to all of these problems. We don't need to worry about measurement so much anymore. That's why I think it's useful to talk about that case where the model broke down. It's a very good thing that the CDC didn't just abandon its program to collect data on flu incidents from clinics in light of the 2009 paper, right? You might have said, given the 2009 paper, oh, no more need to collect the data from clinics because these predictions appear to be working so well. Clearly, that would have been quite problematic. So I think we're not at a point yet where machine learning is really a true substitute for traditional data collection methods. And then third, I think the third lesson you get from this is often people think of machine learning in some black box sort of way, that I'm just going to feed the data to the machine and it's going to tell me an answer. But I think as this illustrates, that's clearly not right. You both need some technical skill to figure out how to fit these models, but also careful judgment about whether the model really makes sense, right? So fitting a black box model, I think, can be quite tempting to do these predictions, and that is in fact a lot of what people tend to do, I think, in this area. But my sense is the models where the mechanisms that are underlying seem more sensible are more likely to yield stable predictions. So in particular, what I mean is if you're getting predictions off of terms like Oscar nominations or high school basketball, we saw some of the searches that they were effectively using to predict the flu incidence. You should start to worry that maybe something's going to change such that the high school basketball season no longer correlates with flu, or something else changes about the nature of searches, right? And so that's where, if the underlying predictions actually make sense in terms of being related to cough or fever, and you kind of understand the way the platform's set up and that it hasn't changed, I would think you would have much more confidence in using these predictions going forward than just kind of letting the model run and using whatever the computer spits out. So I think there's still an important role for human judgment in addition to using these machine learning tools, which are increasingly popular. So any questions on the Google or health stuff before I move on to the next topic? Anyone? Okay, great. So what we're going to talk about next is a similar set of methodological issues, but in a very different context, in the context of criminal justice.